problem going to be the issue of the money trail of trying to understand our leadership in terms of if you look at the...
Is that possible?
Well, that's you're part of the money guy, and I know we talked before about whether it be campaign reform or something, but when you look at the 6 Blue Dog Democrats that were holding this bill back, all come from little districts that the money that came into their campaign funds, one could argue, did not have an influence to it. And so it's like crazy. See, I deal with people that are psychotic, but by and large harmless. But I worry about the person who's got a method behind his madness.
Who's not harmless.
And so is that part of the problem of it's a question of, so you want to make a living, but then we have other people trying to say, well, we need to fund this, and so how can you and I make a living? And then somebody else say, well, we need to make a living off of the product that we sell you. And this issue of is money part of the problem in our government?
What we need to do is to start off, we need to understand the problems, because we have universities that are private that compete with government universities. We have, you mentioned Federal Express, it competes with the United States Postal Service. It is a fallacy, and it's a dangerous one, to say that you have to drive, that one party needs to drive the other one out to make this work, because it's not true. But let's get back to insurance.
Good.
Part of the cost driver is not having 100% coverage.
Oh, bingo.
And there are a couple of reasons for that.
I completely agree with you.
One reason is that the hospitals, for example, they don't know what their costs are. I think you're wrong that the costs in the medical business can be transparent, because you don't know what your costs are. Not really. You don't know what it costs to run the ICU on a per patient basis, because you don't know how many people are going to be in there. So you have to set those prices in advance. And you also don't know how many people aren't going to be able to pay you from the hospital's perspective. So at the beginning of the year, when you set your budget, you have to set your price, and you bring in an estimate of the number of people that won't be able to pay. You bump your prices up to cover that. You have to stay in business. And so the lack of 100% coverage creates this uncertainty premium, because you have to estimate that at the top of that range. If you underestimate it, you lose money. So you overestimate that, and it drives costs up just by virtue of knowing that you've got to treat people. You have to when they come in, right? You're not going to turn them away.
A couple of quick things, though, when we're discussing the analogy between UPS and FedEx and the post office. This is what makes the healthcare issue so incredibly complex. It's not exactly the same when you're talking about private insurers or private practitioners competing with the government, because the government is already, because of CMS and Medicare reimbursements, they are already threaded into the functionality of the private market. And the irony is, this is the one I really love. The federal plan, the federal government plan that the federal employees in Congress are insured on, they don't pay CMS or Medicare reimbursement rates. Their reimbursement rates are tremendously higher than the rest of us. So therein lies this little rub on, well, yeah, we've seen instances in the past where you've had private enterprise compete with the federal government. That's, I agree with you, that's all fine and good. But we already have such a convoluted crossover system because of the reimbursements already in place that it makes it really, really tricky to pull it apart.
It's going to be really hard.
It's dicey.
But there are some, am I correct? Tell me if I'm right here. If Medicare says I'm only going to pay X dollars for this procedure, generally then the private insurance companies peg that, and they'll be 140%.
That's right.
Yeah.
They take it and
they'll set their rates, they'll take a Medicare rate, and then the negotiations with the physicians and hospitals, and this is where you get the differentials between the states. They will do Medicare plus 10, Medicare plus 20 or 30% or whatever. So you're right. And that's also where the rub comes when Congress does their budget and they change the reimbursements on Medicare. Well, everybody else slides with it. Because it's already tied to a federal benchmark, if you will. The coding is all federally driven, CPT codes. I mean, all of this stuff really comes into play. Nothing is going to get fixed in this country until we fix three things. They're going to be the gorillas in the room, and they're going to be really tough and probably next to impossible. Transparency, which we've talked about before, agree with you completely. Now, we may not be able to get complete transparency on the emergency room runs. You can't calculate that. What we can do is start with, and this might be a good beginning point, start with the small things. If we purchase insurance for what it was meant to be, you have a deductible, you go on down the road. We have been spoiled rotten with copays. First dollar coverage has killed us. We have used and abused our system, and we're paying the price for it. But if we peel that back and we have high deductible health plans, keep the tax, improve the tax advantages, allow seniors to get those tax advantages. Get as much transparency on middle and small things. If I have an HSA, I want to know how much is my medicine going to cost me, and I want to know how much is it going to cost me to go see my doctor. Those are fairly, I would think, simple things that technology could whip a card through and say, oh, on this plan, your discounted cost is going to be $100 for this office visit. I'm a happy camper. I write the check and go on down the road.
The medicine part's a little tougher on that, though, right?
Actually, right now today, we get quicker reads on discounts on medicines on the spot at the pharmacy than we do in the provider's
But
offices.
you said, like, from your initial starting point, I want to know as a patient how much the medicine's going to cost me. It depends on the medicine.
Oh,
Right.
sure, absolutely.
So, you tell me, I guess you can enter some plans, it's going to be $2 or $10, but.
Yeah, absolutely.
But,
absolutely, you can
that
find out
becomes
from your pharmacist what your discount is. We've got to fix transparency. Here's the big one. We got to do something about immigration. Our local hospitals are dying on the vine. Our Texas hospitals are dying on the vine with unreimbursed care. And, okay, I completely lost my train of thought. Transparency, immigration, and I know, and it was so profound.
Well, but
Don't you just hate that?
But to go back to
Senior
immigration, to talk about, for example, we have the Lubbock County Hospital District.
Yes.
And so,
It's all of them.
orthopods out of med school are on salary, right?
Well,
Or they're in a proportion of their, but the thing is, is there going to come a day when your group can't compete with the person who, in the end, when UMC runs a little short, they just turn to the taxpayers. And we're seeing that grow and grow and grow. And so is that part of the difficulties? People are just now starting to feel that pain instead of saying somebody else is paying for it. Now they come to realize we're paying for it.
well, let me underscore a huge fallacy about salaries paid to physicians being somehow a way to save money. First of all, as Beth can tell you, if I am a salaried physician at the Mayo Clinic and they decide to pay me as an incoming orthopedic surgeon the standard $350,000 a year, they're going to give me an incentive. That $350,000 a year is predicated upon them understanding that I'm going to probably see X number of patients per month and do X number of surgeries per month in my specialty. So if I'm a hip and knee replacement guy, they're going to say, you're going to probably do 35 or 40 hip or knee replacements as an average. And if you're busy, you're going to do 60 to 70 hip replacements a month. Every hip replacement, whether it's on a private insured patient or a Medicare or Medicaid patient, is billed the same way by the central billing office of Mayo Clinic. They get the exact same amount of money sent to Mayo Clinic, whether I'm getting paid for each piecemeal work I'm doing or not. There's not a dime saved on a salaried physician because the money is held by the hospital or office entity, be it Scott and White, Mayo Clinic, Cleveland Clinic. So for when you read an article that says, God, if they just paid all the doctors $500,000, we'd save money. Because they don't lower the cost of that hip replacement. That money just goes to the hospital or that entity. And what are they doing with the money? They're going to build new offices, new buildings, and that's not going to save a dime
But now, isn't it true that it actually is cheaper than the Mayo Clinic? And I don't
No,
think it's because
no, no.